Morning, everybody. We'll get started here in a few minutes. All right. Good morning, everybody. Thank you for being with us today. Welcome to the Centralina Area Agency on Aging April webinar. It's sexual abuse and long-term care, a team approach to preventing abuse and protecting residents. Just going to go over a couple housekeeping things. So we are in a Zoom webinar feature, so you are automatically muted. You cannot see other participants. You can only see speakers and hosts. If you have any questions, you are able to ask questions. Just please do so in the chat box. This session is being recorded. We will have it posted on our website for you to view later, for you to share. We also have other resources posted on our website. And we'll also be sending a follow-up email, so you'll get all the information from today. Today's speakers, we have a panel of speakers today. We're very excited. So we have Lori Abinader, who's an aging specialist and ombudsman here at Centralina. Lori Clark, who works for Atrium Health Sexual Assault Treatment Center. Cindy Kincaid is our lead ombudsman here at Centralina. And then we should have Wendy McGuire, the deputy sheriff at the Cabarrus County Sheriff's Office. So I'm going to stop talking. We have a lot of information on the speakers, and I'm going to pass it over to Lori Abinader.
Wonderful. Good morning, everyone. I am going to do a few clicks and do some screen, share my screen real quick. And it looks like my presentation is not where I thought it was going to be. So let me go one more place. And now it should be where I want it to be. There it is. Okay. It is a pleasure to be with you all here this morning. I'm excited to share this. I've wanted to do this presentation topic for a while now. Just very excited to see the folks who have turned out for this training. And Caitlin, how's the screen looking? Do I need to switch it?
Yeah, switch it over to the other view.
How's that?
That was perfect.
Okay. So I have a lot of information to share with you all today, and then we have 3 other speakers. And so I'm going to try to make the very best use of our time together today. We are going to talk today, of course, you know this already, about sexual abuse and long-term care. I appreciate you taking the time to take time from your busy schedule. We're going to dive a little bit deeper into this issue. And we've got some great local experts who are going to be with us today. So without any further delay, let's jump right into it. I'm going to let you read over those session goals. This is of course, some of what we want, what we hope you will get out of this. I hope you'll get more from this than that, and also know some different contacts and feel better about how we go about working together as a team to combat sexual abuse, any type of abuse. And what we've learned over the years is that elder abuse is such a big monster that we have to be working together. No one agency can combat abuse by itself. No one facility can combat abuse by itself. So we're going to be talking about how we work together, and also just cover some of the basics. So I'm going to start with the basics. I'm going to move quickly through that, and then I'm going to get into more of the meat of what facilities can do to combat abuse in their own facility. A special note as we go through today, when I talk about long-term care or I talk about nursing facility, just know that those, for our purposes today, those are all interchangeable between nursing home, assisted living, family care home, because if you take the measures to combat it in a nursing home, you're going to take the very same measures in an assisted living or family care home as well. Also, I'm going to use the word resident a lot today. I know some folks are used to using the word patient if you're from the hospital setting. And I just wanted to mention that for those of you who are joining us who work in the home health industry, or you work in some type of home and community-based services, when we talk about resident, what we're talking about could easily translate over to your clients. So I wanted you to be sure that you understand that this is a broader issue and certainly can be pushed out to the bigger conversation to combat abuse, not just in nursing homes, but if you work in home health, if you work virtually anywhere, that these many of these same topics and tips and information should be useful no matter where you are. Okay, we're going to talk quickly and start with an overview. The definition of sexual abuse is any non-consensual sexual contact by one person upon another. It's also important to note that sexual contact with any person who's not capable of giving consent is considered sexual abuse. Of course, a lot of times there's deceit and manipulation that's involved. Also want to mention that sexual abuse is just one form of elder abuse that we're zoning in on today. But like all types of elder abuse, sexual abuse frequently goes underreported, underinvestigated, or unnoticed. As far as the different forms, and sexual abuse can take many different forms, there are, and you'll see this long list, many different forms of abuse, of sexual abuse. I'm not going to read all of these to you. I will draw your attention to human trafficking, which can be an issue among the elderly. There are unlicensed homes, usually some of our small homes, unlicensed homes that have individuals living there where they are being human trafficking is involved. Sometimes they are being exploited sexually, usually being exploited financially. So human trafficking does exist. It does exist in our area. And so that's one that most people wouldn't necessarily think about that's important to know. Also want to draw your attention to this last one, talking about sexually explicit photographs or an audio or video recording of an individual in any form, especially and including someone who is receiving care. If you all remember, this was a story that hit the news not too long ago, and it was someone who had taken a video or a photo, and the care recipient was not dressed, and the video hit some type of social media. I'm not sure if it was Facebook or Twitter, but and that was considered sexual abuse. So it's important to know that most facilities have a guideline or a policy that they cannot photograph or video residents, especially in a care setting in their rooms. So that's certainly one that we want to draw our attention to today. Okay, next, let's talk about the prevalence of sexual abuse in long-term care. According to the World Health Organization and a report they did, compared to other nursing home abuse, sexual abuse is considered to be fairly rare. It's usually the least common of all of them. But we're going to talk about what least common actually means, and I want you to determine whether this is the message we want to be sending out about sexual abuse being rare. Sexual abuse was the least reported type of abuse out of all the other types, but 1.9%, so roughly 2%, that's 2 people out of every 100. So 2 out of every 100 nursing home residents or their guardians or loved ones reported some type of sexual abuse. I'm not sure that I feel that that is all that rare when I see that number. I don't know about you guys. There is no national database on sexual abuse in nursing homes, and there's no data in our adult care homes. that is collected either. So really the long and the short of it is we don't know the full scope of the problem. And that's true for all forms of elder abuse. We're really just getting started and just scratching the surface of understanding the problem. The prevalence of sexual abuse in long-term care, reporting barriers can be an issue as well. Of course, you guys have heard this. Many of our older adults do not talk about sex at all, and they're certainly not going to talk about a sexual assault. So that is a barrier and a social stigma that we have to try to work around if at all possible. There's also the fear of the retribution by the perpetrator who says this is going to continue or this is going to get worse if you report this. There's also the fear of being evicted by the facility for complaining, and that has happened. We're actually going to look at a case study where that happened to an individual. And residents with cognitive issues or intellectual disability may not be able to report the assault or may not be able to fully give details about the assault. So we definitely have some barriers going against the sexual abuse prevalence and it being reported and getting a good number on that. From some nursing home survey data, this is more information about the prevalence of nursing home sexual abuse. According to the Administration for Community Living, that's where Medicare and Medicaid are housed, there were over 20,000 complaints of sexual abuse over the last 20 years. So 20,000 complaints. Again, I'm going to just play devil's advocate and ask you, is that rare enough for us to consider that sexual abuse is rare if 20,000 folks have complained about it over the past 20 years? So this basically equates to about 3 people in nursing homes every day are being sexually abused. Between 2013 and 2016, more than 1,000 nursing homes were cited by their state survey agency for mishandling abuse reports. That also included failing to investigate and report allegations of sexual abuse or for not screening employees of past sex crimes. Many nursing homes take sexual abuse cases very seriously, but there still are reports of many facilities that try to sweep cases underneath the rug. And that is a good segue to our next slide, the case study that I was telling you about, where the victim was kicked out of her facility. Excuse me, this is that case study. There were multiple accusations by multiple victims against the same one man who worked as a CNA, and he worked at several different nursing homes in the North Carolina mountains over a period of years. The first victim who openly complained was ignored by her facility, and she was then committed to a psychiatric ward, basically because she was so upset about what had happened to her. And you can go and read more about this case if you'd like. I'm just giving you the highlights. So a couple of months later, 2 other women at the same facility had called 911 to report separate assaults. And at that time, the officer who was investigating remembered the resident that he had transported to the psych ward months before, the first lady who complained. And he remembered that she said she was glad to be taken out of the facility because an employee there had raped her. So he was able to circle back and get her statement as well. So even though she was the first one to complain, she ended up being the third resident considered a victim in this. And that went on to find 3 additional residents at other nursing homes that this gentleman had worked at over the course of his career. They went on to find 3 other complainants as well. So I think it was a total of 6 accusations by 6 victims by the time the investigation was all done. He was sentenced to spend somewhere between 23 to 42 years behind bars, and the nursing home was cited for failing to protect residents and fined $110,000. So wanted just to point that one out. This actually, I think, comes out as a success because the perpetrator was actually caught, and the nursing home was held accountable. But it is important for us to know that this happens, and this individual had worked at multiple, this individual was working at multiple nursing homes, and his pattern of his behavior was the same. Okay, moving on, let's talk about some signs and symptoms. So this first slide talks about the physical signs and symptoms. I'm going to move right past this because we have Lori Clark, who is a sexual assault nurse examiner, and she's going to talk to us about the signs and symptoms, and she can do a much better job than I can because she's an expert in this field on that. But I'm going to jump on over to the behavioral and psychological changes that we see. Important for everyone to understand that after someone is sexually assaulted in any way, that we may see behavioral changes. And this is just a beginning point to understand what we might begin to see. And it can be anything from fear or avoidance of a particular person or a particular place. If the assault happened in the shower room of the facility, that resident may suddenly stop agreeing to take showers, and we don't know why. And our job is to ask and say, what is it about the shower? Is it too cold? Did something happen? And really getting into it. So we might have someone who has never once before tried to flee the facility, and they start having exiting behavior, trying to leave the facility, and they're doing it because they don't feel safe, and they're trying to get away from the person who assaulted them. And there's many others. We do have our second webinar in this series is coming up next week, led by Kara Lemon, who's wonderful. And she's going to take a deeper dive into providing care once someone has experienced trauma. And I'm probably not explaining that perfectly, but it should be a great presentation. And she's going to spend the entire time talking about how we respond to someone who has experienced trauma. So I will move on from here. Just know that when we see any type of sudden or unexplained change in behavior, this is an important thing for us to pay attention to. It's also vital for us to understand that sexual abuse, like all of the different types of elder abuse, sexual abuse may co-occur with different types of abuse. So the individual who provides care and also is the sexual, who is the offender, may also say, I'm not going to bring you your pain medicine, or I'm not going to bring you food this weekend if you don't agree to do what I say. It may be emotional abuse, physical abuse that is coinciding at the same time. It may even be financial exploitation. Just important to know that when abuse is involved, a lot of times abuse isn't just limited to that one type of abuse. A lot of times so just be on the lookout and know that. Real quick, let's look at who the victims are. It's not going to be a surprise to anyone. In most cases, our victims of sexual assault are female, but this is not always the case. There certainly are cases where males have been victimized. In a lot of cases, the victim has some type of cognitive decline or has some type of intellectual disability. It is vital for us to understand that and know that these two populations, well, I guess it's three populations, are females and individuals who have cognitive decline and individuals with an intellectual disability. All are more targeted than anyone else in our facilities and even out into the community. So important to know who the typical victims are, but also important to know that it can really be anyone else as well. Okay, next, let's look at who the perpetrators are. Our perpetrators in facility setting, it really can be anyone who has contact with residents at any time. It can be staff, visitor, volunteer, a relative of the victim themselves, or even a different resident's relative. And we have accounts of that happening. The offender is usually a caregiver that the resident knows and depends on for assistance. But sometimes we do have that stranger assault, and our elderly population is just as vulnerable to stranger assault as the rest of the population. Another important factor is we have resident to resident abuse, which sometimes can be sexual abuse. Sometimes it manifests as physical abuse, and other times it shows as sexual assault. And this can be a resident, the offender can be a resident who has capacity and is preying on residents who do not, or it can be a resident who lacks capacity and simply needs more supervision than he or she is getting. So important for us to know, in many cases in a facility setting, staff see these clues. They see that a resident is starting to pay a little more attention to Miss Jones, or that he is entering Miss Jones's room at nighttime, and things like that. So we often see those clues leading up to some type of sexual assault. There's also a gray area here, if you will, and that's when we're talking about the spouse of an individual who let's say has some advanced dementia, and that spouse expects an ongoing sexual relationship like he or she always has had, despite the fact that his wife, let's say, now lacks the capacity to consent. So it's important for us to understand that the victim and the spouse both may not consider this abuse. Okay, steps to protect your residents and protect your facility. First and foremost, develop a very comprehensive abuse policy. Immediately intervene and stop the abuse. If it is being observed, the staff must jump in there and protect that resident, stop the abuse when it's happening right away. Do not go and get someone else for help. Do not call your administrator first to ask what should happen. Staff need to know that they must intervene immediately to protect that resident. Secondly, they need to remove that perpetrator from the resident and the resident's surroundings. Then they need to be supervised and kept until law enforcement or administration arrives. But they can't be just told to wait up front in the lobby or wait in the administrator's office. They need to be supervised, because what you don't want is for the state to come in and do their interview and find out that this individual was left alone in the presence of 99 other vulnerable residents. You want to assess the resident for injuries, notify law enforcement and administration, of course, and preserve any physical evidence of the abuse. And we're gonna, I think, both Wendy from the Cabarrus County Sheriff's Department is gonna talk about this, and also maybe Lori Clark, our nurse examiner. So I won't speak to that in detail. And then on an ongoing basis, the resident needs to be monitored for depression and all sorts of other things, and to be linked with any type of appropriate victim services or any type of psychological support, such as a rape crisis center or victim advocacy or something along those lines. Okay, so that's the policy. Step 2 is to cultivate an abuse-free environment. It's important that your staff know and have been encouraged to report anything that they see that is suspicious. Your staff hears a lot about what's going on and don't always feel comfortable reporting it because they feel like a tattletale. In a case where their facility is on the line for keeping residents safe, they need to understand they must report if they see something suspicious, or they hear about the new nurse who was hired who works night shift, and they just think that there's something going on there. The residents seem upset after he's in their room or something along those lines. We need to have more supervision and presence on the floor of all of our facilities. I know that is a hard pill to swallow, but staff and residents and visitors, everyone needs to know that the facility is going to be vigilant about preventing abuse and maintaining an abuse-free environment. Make sure your staff know and believe that sexual abuse can happen. It does happen. At the end of this presentation, which you'll get a copy of, at the end of this presentation, it talks about, there's a link to different resources and some other rich reading materials. There's plenty in there about abuse, sexual abuse that has happened right here in our own backyard, right in the greater Charlotte region. So it is important to know it can happen, it does happen. Make sure that your staff don't have the attitude that these folks are old, nobody's going to want to have sex with them, which is a very common thought. And it's important to think this can happen in my facility. I've got to be the one who keeps an eye out to make sure it doesn't, if at all possible. Also encourage residents to voice their concerns. Make sure residents don't feel like they're going to be retaliated, like the lady that we read about earlier, that she's not going to get kicked out of the facility, that he or she's not going to be seen as a troublemaker or a problem resident. A lot of times our residents say that that's an issue for them. They don't want to speak up and say that. And maybe invite your law enforcement contacts to come out and speak to staff and get to know them. Reassure them that it is okay to call 911 when there's an emergency. Your staff needs to know that. Your residents need to know that as well. Okay, moving on. Step 3, this one's my personal favorite. We need to train our staff and retrain our staff. They need to know all the things that we've talked about today, what sexual assault is, how to report, facility abuse policy, and this one, which is my favorite, your staff need more time invested in them than the annual 30-minute elder abuse in-service. I'm going to say that again because it's worth repeating. Many facilities will say, we need to do our annual elder abuse in-service. I've got 30 minutes to give to the presenter, and there you go. I'm going to challenge facilities to do more than that. Maybe set it up where there's, maybe if you do monthly in-services, do 3 different ones. Do one, and I've got a little sample curriculum here for you. Maybe do one on elder abuse identification. Do another one on sexual abuse and assault, and then do another one on how to prevent and identify financial abuse. You cannot train your staff enough about how to respond and react to abuse. So I'm going to challenge every facility who is on this call today to think about having more than just the 30-minute abuse curriculum where you have everybody say, what are the 5 types of abuse and who do you call to report? Your facility staff need to know more. They need to know what to look for when it comes to neglect and spend time on that. And they need to know what to look for when it comes to sexual assault and spend time on that as well. So that's enough on my little soapbox, but I'm going to encourage you, invest that time in your staff and train them so that they will know how to protect your residents. Okay, step 5, and this is the last step. I ran across this one. This was something that I ran across, and it was created by the Ombudsman Agency of the Bluegrass. So it's friends of ours out in Kentucky. And they came up with this. It's called the Healthcare Workers Sexual Assault Safety Plan. And this first slide explains what it is. The second slide is actually a sample of the one from Kentucky that they share. But they have every resident in their facility, when they do a presentation, they have everybody sign this, and it goes in their personnel file. So it is, simply saying, we've trained you, and I know what I need to do. So we can look through this just a little bit. I am preparing to protect residents from sexual abuse. I can't control an abuser's violence, but I do have a choice about how I respond and how I keep residents safe. And it goes on from there to say, in this situation, I will tell so-and-so, and if that person doesn't listen to me and take immediate action, I will tell this person. If the abuser's still in the building, I will do this. So it gives each and every one of your workers in your facility a plan to say, this is what I'm supposed to do, no matter what. And staff sign it, the administrator signs it, or you could have somebody else sign it if somebody else does the presentation for you. But I think this could easily be a powerful way for our facilities to make sure staff know we expect each and every one of you to play a role in protecting the residents. Okay, so this next slide is just some of our sources and suggested reading. There's a lot of great information here, and you're welcome to holler at me and ask me if there's anything particular that you're looking for. A lot of times I can tell you where you might be able to find that. And I thank you for listening to me. And next, we are going to jump over to Wendy. Wendy McGuire is a sheriff's deputy in Cabarrus County. I've known and worked with Wendy for a long time on the Cabarrus County Elder Abuse Task Force, and I know that you're going to enjoy listening to Wendy with us here today. So I will see you guys back when we do questions at the end of our session. Thanks.
Thank you. And I will say I'm normally in uniform, but I'm off this week, so I am at home and relaxed. So. So to start with, I do want to say that I think it is wonderful to have law enforcement to come out into the facilities ahead of time. And one of the guiding questions that Lori had put on here for me was, when do we call law enforcement? So the truth of the matter is a lot of times with elders, just like with children, they need to be able to understand or have some type of connection with law enforcement to see that, you know, every time we show up, it's not a bad negative thing. So if they have that kind of connection with us where we come out and speak, we come out and talk about other types of things, then they can have like the actual human connection with us a little bit. And that would help us as well to be able to kind of be familiar with the facilities and things like that. So us coming out early to interact, even if it's about something totally different, if we're coming out just to kind of address other issues that they may be dealing with or you guys may be dealing with, for us to come in and actually just be interacting with them is a great thing, because we can kind of have a little bit of basis and background connection with them to make it a little bit easier for them to speak up and say something, as well as the employees in the building. The employees in the building feel comfortable speaking with us and realize that we are there for positive reasons and we are there to try to help. Then that's going to give us the ability to be able to step in and do a little bit more and possibly help someone to speak out faster than what they would. I love the example that she gave where there was multiple. I don't enjoy the fact that it happened, obviously, but I appreciate that there were multiple incidents that had been brought up and brought to the attention of individuals. So that leads me into also when to call law enforcement. If you have that gut feeling of something's going on, and then you get the behavioral and psychological changes that she mentioned in one of the slides, you have the connection of both of those things. I would suggest immediately start documenting all of the things that you've noticed. Document as much as you can, because if you have all of that documentation and then you call us and say, you know, I feel like there's something going on, if you even don't have that evidence at that point, like the pictures or like some type of, you know, actual confession to you, you give us that information. And even if we come out and say, okay, there's not enough for us to do at this point, then if somebody else comes forward 3 months down the road, we're able to actually connect that a whole lot easier because we can pull up and say, okay, we were here 4 months ago. This is why we were here. And then we can make contact with that officer and get the information that that officer obtained and possibly connect more cases. Sometimes it could be a connection to other facilities as well. So definitely documenting all of that, because when we come out and we see the things that you've documented, sometimes we may be able to pick up on additional things or be able to kind of go into questions to you that you may not have thought of, that we can connect with the things that you've written down, as well as in the moment when you're calling us and we show up, it can be unsettling. And for you to have all of that stuff documented and written down to show us, we can kind of speak a little bit more calmly about it and figure out where we need to go next with it. But always call if you have that gut feeling, you have that concern, you have the behavioral and psychological changes. Always call. We're working. There's always some of us working, and us coming out, even if we're there for 15 minutes, don't feel like that was something that was a waste of time or something, because it could be something that leads to a different investigation that helps us down the road. So definitely always call. What to do and not to do with a client. So a lot of times, a law enforcement, obviously not wearing my pink shirt, I don't seem, I don't seem as stern, I guess. But a lot of times as law enforcement, we show up on scene and we are very, it may seem like we're emotionless. That is intentional. We have to be that way, because when we are coming out, we have to get straight to the point. We have to, if that's my grandmother, I want somebody that's coming out and I want them to be on point. I want them to be focused. So your job for us in that moment, for that person, for that individual, is just to be present. You just being present is what we need in that moment. Don't ask them questions. If they start talking about it, try to reassure them that you're there, you're with them, you're going to stay there with them, as long as you are able to, that sort of thing. For us, if you start having that conversation with them, it can put them in a direction that once they are being questioned, it can change what they may be saying to us. So we need that genuine reaction of what they're telling us, to not have any kind of communication or any kind of other words that have been maybe thought of by someone else that they're using at that point. We need their wording, their specific incident that has occurred. We need that from them. As far as the room itself and all of the things in the room, I know that Lori Clark's going to address a lot of things about the physical person. But what I was wanting to focus on more was about the facilities and the things that you would be kind of interacting with. So if you guys call us and an incident has actually happened and you have stopped that incident from happening, at that point, nobody needs to be taking the trash out. Nobody needs to be washing dishes. Nobody needs to be laundering items. And that's for the whole facility at that point. And the reason why is because a lot of times, if you have that perpetrator has done whatever act that they've done, at that point, we don't know what areas of that facility they have touched, what areas they have been in. And so anything that they may have touched, or, if they are in a neighboring room and they only come over for 30 minutes, that neighboring room is being cleaned while we're in the room beside it. That could be taken away, substantial evidence that we need, even if it's something just as minor as a cup or a trash can. That includes the outdoor trash cans as well. If you have outdoor trash cans that have been removed from the facility and they've been rolled out to the road, somebody needs to be thinking about, okay, I'm going to go ahead and go grab those and bring them back close to the building to make sure they're not picked up. Minor things like that are a really, really big deal when it comes to a bigger investigation like this, just because we are able to get all of those kind of things. And there are oftentimes, I can't tell you the amount of times that I've gone through trash at crime scenes and been able to get substantial evidence from it, just because of the fact that people just do not think about discarding things as being something that's going to link them back to something. And it happens very often. So that is important as well. The next thing I wanted to kind of address is, it's going to take us time. It's going to take substantial time for us being there. And we will need, if you have video, like of the hallways, entryways, all of that kind of stuff, we need to know how much time you have on those videos. If those videos get, if they start recording over themselves in 24 hours, we need to know that right away so that we can make sure that we get that same day and not the next day, because we will go for days and days coming out and questioning people and doing lots of paperwork things. You'll probably see us the first 3 or 4 days. You'll see us numerous times. So for something like that, where it's going to be detrimental for us to get that video, we need to make sure that we have access to that pretty soon. So if there's somebody that needs to be called so that we can access it, that's a good call to make kind of quickly. Visitor logs and things like that, just making sure that those types of things are legible, that they're updated and that they're kept to where they're going to be accessible quickly for us. Those are very important. If we can't read the last 10 names because people are just scribbling them and we have no idea who they are and there's no true documentation separately of who they are, then that's going to take us a lot longer to be able to go back and eliminate people. Even if it's, Sue's grandson that always comes and who he is, if we can't immediately know that person is who that signature is, then that's going to take away some time that we could be getting to the actual perpetrator a whole lot faster. So those kind of things, even though they seem minor, can be a huge help for us. It's going to sound, I'm not sure what the word would be, but if someone were to pass away from the facility and you feel like, something's going on it's not, there was something that may have been connected, that's still also something that we can address too. If you feel like that there was abuse connected to that, and it possibly could have been sexual abuse, there could have been sexual abuse connected with that, there could have been something that is connected, then that can be a law enforcement call too, just to say separately, okay, I know that law enforcement and fire and EMS came out when this person passed away, but I kind of wanted to speak to you guys separately from that incident, because I felt like there might be something going on that maybe wasn't actually what happened. It may not have been, old age or a basic sickness. It may have been something that was a contributing factor to what was going on. So those underlying issues and those things are super important for us to know, because if we don't have that day-to-day interaction that you have with them, we are not going to be able to pick up on something like that if that were to occur. So even after the fact, that's still a time frame that we can be talked to and we can still address it, because like the incident she gave, if one of those residents had passed away, they could still include some things connected to that, or that person could still be traced back to other people potentially, to make sure that there weren't other victims there. So always remember that too, I guess, in your job. How we work with long-term care facilities, forensics and other agencies, it's kind of, I guess it's kind of like we all know, when we were starting this out and I saw that Lori was on here, I was like, oh, okay. Because I knew that she was going to cover a lot of things that are going to be things that we would look for on the scene. And a lot of things that we're going to talk to the individual about, we're going to question them about. She's going to do some of those same things. She may do again, but she may do it in a different way. She may do it 2 days later. She may do it, 5 hours later. I don't know. It's, but some of those things are going to overlap. So I knew, initially that some of the things that I would address is going to definitely overlap with what she's going to address. But we all work together and oftentimes see each other, in different agencies like that, just because of the fact that we do work directly with them a lot of times. And so we do communicate with each other, but at the same time, if it's information that you feel like may have been given to law enforcement, but wasn't given to the forensics nurse, or, during an exam or something, you feel like that information may not have been shared, it's okay for you to go ahead and share that again, just to make sure that that is something, that has been addressed or was addressed in that instance. And even if law enforcement comes out a second time for an incident, it's definitely always a good thing to say, okay, hey, you guys were out here 2 months ago. I just want to make sure that you were aware you were out here 2 months ago, because we also, I may work one day and not work for 3 days, and the new squad's on. And I was always meticulous about looking up to see what the past call history was for the address that I'm going to, but not all officers do that. So if you are able to say, okay, you guys were out here a couple weeks ago, it was for a different person, but it was for the same type of call. So, just wanted to make you aware. That's always helpful, just in case. We appreciate information. So you're not going to be oversharing with us if you give us those types of things. That is all I have. I think that a lot of my stuff's is gonna overlay on what Lori has, but I appreciate being here, and I thank you all for what all you do. Elders are a passion of mine, so I enjoy when I'm able to do something to help out. So thank you all for being here.
Thank you so much, Wendy. I appreciate you taking the time to be here, especially when you're not on duty today and possibly on spring break. I don't know, but I so appreciate you being here. Next, we are going to move right over, and I'm going to pass the microphone on over to Lori Clark, who is also someone that we've worked with on the Elder Abuse Task Force in Cabarrus County. Lori is now working in Union County with Carolinas Healthcare, and she is a sexual assault nurse examiner. So thank you, Lori. So appreciate you being here.
Thank you for having me. Let me see if I can get this to work really quick. Can everybody see that okay?
Looks good.
All right. So I did a very short and brief explanation of things. I tend to talk really, really long, and so I tried to keep it very, very brief. So if anybody has questions about me needing to elaborate on things, just shoot me a question or an email at the end, and I'll be glad to answer those for you. So like Lori said, I have been a sexual assault nurse for many years. I've been with Atrium Health for about 30 years, and about 18 of those, maybe 19 now, it's been so long. I've been in the forensic side of things. I've always been off and on an ER nurse for the most part of my career, cardiac being a little blip of my nursing world was in cardiac, and the rest have all been either emergency room nursing or the forensic nursing part of the nursing side of things. So I've had lots of cases come through. So I see all manners of ages, from infants all the way up to the elderly. So I've seen a whole bunch of different types of patients come through. So this is what I'll be talking about: what forensics is, the sexual assault explanation, the forensic exam, what that really means, working with law enforcement. And again, like Wendy said, some of what I do and some of what she does kind of overlaps a little bit in the way we handle our situations, but we work really, really well together with all of our law enforcement agencies. We work also with Department of Health and Human Services, or DSS is like, I mean, I will always call it DSS, but they've changed names. So we work well with them too. We make phone calls to them as well for all kinds of reports for child abuse and elder abuse. And then what the facility role might look like. So an introduction: in the United States, sexual abuse is, like everybody says, the least reported type of abuse within all ages, not just the vulnerable adult, but those are also not reported as often as they probably should. And it's because it's often a hidden thing that we're not seeing, or we're not picking up on the clues, or the patients are so vulnerable to the point where they're not cognitively able to tell you what's happening, and we don't see it until much later. So it can occur within the community, in the home setting, in long-term care settings. It can happen in the hospital settings. It can happen just about anywhere, really. It is important to, of course, recognize and respond appropriately to these types of situations. And we have to be cognizant of possible evidence so we can kind of keep that safe until law enforcement arrives to wherever you guys are, that they can take that off your hands. Or in my case, when they come to the ER, I've already got things categorized, labeled, packaged, and ready to be taken to law enforcement. So it's important to be able to recognize what potential evidence could be. And like Wendy was saying, save it all. Just stop what you're doing and save everything and let law enforcement or the forensic nurse sort it out once they arrive on the scene or once the patient gets to the hospital. So that way we know that we're preserving as much as possible. So forensics, it's a broad term that encompasses many different disciplines, and it's basically people that work within the forensic science world or in forensic medicine or in forensic investigations. Forensic science are those who work to examine the evidence that is collected and analyzed. So it would be those that work like in the SBI lab or the State Bureau of Investigations, or if you're in the Charlotte region, they have their own laboratory where they analyze all the evidence that's brought to them for a particular case, whether it be a sexual assault or any manner of criminal activity that's taken place that they needed to collect evidence for. So you're thinking for forensic science, you're thinking like crime lab things like fingerprint analysis, ballistic or bullets, DNA analysis, blood analysis, things like that. For the forensic medicine portion of it, it's all those other people like me who work in the medical field. It could be physicians, it could be nurses, it could be doctors' assistants, it could be PAs, it could be nurse practitioners. Typically, we don't see CNAs, but they help us. They can recognize evidence and come get one of us who has the expertise in and the training necessary to package that information. So everybody kind of works as a team. But if you're in the forensic medicine world, it's everybody with those types of credentials that are able to recognize evidence, collect it, and medically and forensically examine and assess that victim for any sort of suspected crime or any sort of injury that is a result of that suspected crime. We will also identify all the injuries that they come in with, from minor scrapes and scratches to bruises and extensive damage to the body that we might need to repair, like with stitches or with surgery, that sort of thing. We also forensically take photographs, and that's completely different than what we call, I'll forget the term, it's just completely left my brain. Poof, it's gone. Like scenic photography, it's completely different. You're not just pointing at an object and snapping a photo. You have to do it strategically. So you're not only taking one photo of that particular injury, you're taking multiple photos at different ranges, all the way from broadly looking at things to all the way focused in and honed in on that particular injury when nothing else is showing in that photograph except for that particular injury. We also do a photograph that involves scale, and that scale can be a ruler, it could be a pen. You can't see that because it's blurred, but you can use any sort of object that never changes shape, like a pen, a pencil, a coin, a dollar bill, I mean, that sort of thing. And you're lining that up beside the photo, beside the injury, so you can establish how large that wound is or how large that bruise is, that sort of thing. So typically with one of my patients that come into the ER that I'm taking photographs on, if I'm taking photographs of all of their outward injuries, their bruises, their scrapes, their scratches, their lacerations, and I'm also taking genital photos to show any kind of genital injuries, I could have upwards of 50 to 100 photos within that same case. And that's just the medical portion side of it. You also have someone from the crime lab, not crime lab, crime the people that work with Wendy, I can't think of the correct term, but those people that go out to the scene with her and her team, and they are also taking photographs, and they do it in the same manner that we have. They do the same type of approach and logistics of starting out broad and focusing in on whatever particular evidence they're finding. And you always take photographs before you move anything, because once you move it, you can never put it back in that same spot. So always, if you see something that looks like, a piece of evidence, you need to document it. Since you don't have photography in your facilities, probably the next best thing is drawing a picture of it. Sit down and draw a diagram. It could be rudimentary, it could be stick figures or whatever, but just try to document everything that you find and see before you move it, or let someone know that you're moving it and let them snap a photo of it first. We also have medical records, forensic medical record logs that go along with the photographs that are subject to subpoena for testifying in court during criminal proceedings. So in my world, I'm a sexual assault nurse examiner. I'm also a forensic nurse examiner. We also have medical examiners and forensic pathologists that work in the same capacity. So sexual assault can often be referred to as rape. Rape is a form of sexual assault, but not all sexual assault is defined as rape. How confusing is that, right? So the basic way of saying it basically is just rape is considered a legal definition. So they use that in the court process. But legally, it means the penetration, however slight, of the vagina, anus, or any body part with an object, or an oral penetration by a sex organ of another person without consent. So when I say however slight, that means if you are thinking about the female, or the male for that matter, and you're thinking anus or with the vagina, it could be however slight, touching up against that sexual organ, then that is considered a form of rape. It doesn't necessarily mean that that has to penetrate fully into whatever body part they're using for their sexual assault. If you get where I'm going with that, it can be however slight. Sexual assault is sexual conduct or behavior that happens without consent. So consent means they have to be cognitively aware, alert, oriented to person, place, state, the whole bit, in order for them to give consent. So if they've taken medication that makes them sleepy, or if they're taking medication that messes with their cognitive ability to think on their own, or if they have a disease process that does not allow them to answer the question appropriately or be cognitively alert, then they can't legally consent to any type of sexual behavior or conduct. And so that is considered a sexual assault. And it could be an attempted rape. It could be fondling or sexual touching of the body parts. It could be forcing a person to perform sexual acts on someone else. It could be penetration of the victim's body, which is, again, also called rape. So the forensic exam, they can be very quick, from like 30-minute exams if you're not having to collect all the things, or it could be as long as, I've had cases last 12 hours before, depending on the patient and their ability to handle the traumatic events that have happened to them. What you have to do is you have to go slow with these patients, even the elderly. I don't see elderly all that often, but when I do, I take extra care to make sure that they are not being traumatized further, because this particular act that's been done against their body is very traumatic to their psyche. They're not only their mental health, but their physical health as well. And so we have to kind of encompass all of that as we're taking care of these patients, and sit down and talk with them and give them time to process what's happened and to get out of what they remember, so we can get it onto paper or into an electronic medical record. Again, like someone else was saying, we write down verbatim what happened to them. We don't paraphrase at all. So we use quotations on everything. And if they use derogatory terms or curse words, it's fine. Let them do that because that's what their normal is. So you write down their normal on the paper. They did this, this, and this to me, and they used all the terms, then you write all the terms down. But basically, it's an examination that is performed specifically by someone that's trained to recognize evidence and collect it appropriately, and to also assess their medical needs as well, and kind of work in tandem, doing all the things all at once. Nurses are great multitaskers, so we are able to do this task very well. But we also gather evidence, like I said, and it all can be used in a court of law. A sane nurse is what we are typically called, or insane, as some of my colleagues call me, is just the abbreviated term for a sexual assault nurse examiner. And we are the ones who typically perform the task of collecting the evidence out of a State Bureau of Investigation box. Hang on, and I'll grab a box so you can see it. And I might need to unblur my screen, and I'm not sure how I can do that, but it's a box like this. And inside the box, I know it's kind of blurred, but it's just a box. And inside the box, you have lots of swabs and lots of envelopes, and each one are step by step what you need to put in it. And we collect those and go, step by step within the kit. And then we also do a genital exam with a speculum, and we look at the vagina on the inside to make sure there's no injuries there, and we collect evidence there. Anal exams we don't do unless there are actual injuries, and if we see injuries, then we bring in the physicians for that particular exam. We weren't trained, any of our nurses are not trained to do actual anal exams. We do anal swabbings, that's about as far as we go with that. So like I said, there's a two-part portion to the SANE exam, if you will. The first part is the written account of using the patient's own words, and along with observations that we notice, like their emotional state. It's very important to write down what you're seeing them do. Are they curled up in fetal position? Are they catatonic? Are they crying? What is their demeanor like? How are they responding to the questions that you're asking? How are they responding to the outside world as you're trying to take care of them? Those things are very important to show the traumatic effect of that particular trauma that happened to them. And then the other thing is actually collecting the kit. The evidence collection box, like I said, is a bunch of swabs, and we collect accordingly. So working with law enforcement, we do that very well. We have good rapport with all our law enforcement agencies. And what I've always tried to tell my nurses is that we have two crime scenes. We have the crime scene where the incident took place. That's your first crime scene. And then the second crime scene is actually the victim and where the victim is being treated. So if they're being treated in your facility, then that's your first and your second crime scene. It very well could be. If the patient is taken out of your facility and into the emergency room, then the second crime scene would be where they are with me. What this does is it helps, we can work gathering the evidence here at the hospital, so detectives don't have to necessarily split their resources right away. We recognize, we categorize, we package, and we preserve the evidence till law enforcement can get there and retrieve it. The evidence is not lost if we're recognizing it and holding it for law enforcement. And we collaboratively work to give injury details, evidence, and details of the assault and observations to actually help with the investigative process. We're not on the arm of the law, so we always have to make that split, that we do not work for law enforcement, we work with law enforcement. And if we see the evidence, we can gather it and we can package it for them, if that helps. So your faculty roles, you have a resident that's been possibly assaulted. So now what do I really need to do? I think Laurie has already hit on most of these, but these are some of the things that I noticed that we might need to address as well. So you would notify your administrator on call, and you would follow your own incident protocols for your facility. Like Laurie said, if you don't have incident protocols or an abuse protocol, you need to get one. So get with your administrators and sit down and start writing up policies for that. You are considered a mandated reporter. So if you have a suspicion of abuse, then it's okay. Pick up the phone and call law enforcement and call DSS and make an adult report, because they are vulnerable when they live in your facilities like that. If this is a semi-private room, then you probably need to find a location for that other resident to stay until law enforcement has stated it's okay to have that resident back in their room, because that particular room, if they are being assaulted in it, is a crime scene, and we don't want evidence contaminated, or other residents cross-contaminating things, or staff contaminating. So nobody goes in there. Once you get the victim out and the other resident out, close that room off until law enforcement said it's okay to go back in it. Wear gloves when you're handling the victim, the clothes that they're wearing, or any kind of bed linens. The best thing to do is, if you're removing that victim from the room where they were assaulted, leave everything alone. Unless you think it's going to be destroyed in some manner, then you can put it in a paper bag if you have those on the scene. But the best thing to do is just leave it alone, close the door until law enforcement can get there. If you need to clean the victim, that's perfectly fine. We don't want them laying in their own waste. So you can put their adult diapers into a biohazard bag, but don't close it completely off. We need to kind of have it air breathe so mold and mildew doesn't start growing. It grows relatively quickly in a plastic bag. So just kind of put it down in there and keep it open. Put a patient label on it if you have the ability to do that, or put some type of labeling on it so you can determine whose it is. And that means the diaper and any wipes. I would probably not even try to, I would even put your gloves in there too. I would put everything that you had on you while you're cleaning that patient, like the gloves, the diaper, and the wipes, down in that biohazard bag. And then if it is needed, the right people will have it when the time comes. If you need to clean the victim, like I said, you can use the normal procedures that you use. If you use washcloths, just put those down in a separate biohazard bag. So everything's kind of separated. Cloths, towels in one bag, diaper in another bag. And then when EMS and law enforcement arrives, give them as much detailed information that you can regarding what you saw, what you heard, even what you smelled. If something smelled off, it may be the most trivial thing, but if you will tell somebody, it might be the key to bringing it all together. Give a summary of their health conditions and, of course, their cognitive functions. Let them know if the patient is able to respond, if, what type of memory issues they may have going on. And then questions, like I say, you can give them to this email address, which is mine, or you may call and leave me a message. I will answer it and call you back as soon as possible. I know Laurie had put up a slide that I needed to address, and I did not address that in my slide. So Laurie, if you need me to go back and address that, you'll need to pull up your slide for me, because I did not hit on that at all. But that is all I have. Thank you.
I will work on pulling up my slide at the very end when Cindy is done. That way we can talk about it real quick. If you're will you be here for a few more minutes, Lori?
I should be. I should be okay. Yeah.
Okay. If not, I can talk about it if you have to go.
Okay.
So don't worry about that. And last but not least, I'm messing up my little saying there. Last but not least, we have Cindy Kincaid, who is going to drive us home, and she's going to give us some more interesting and great things to think about, and then we're going to move into a question session. So thank you, Cindy, for being here. Cindy and I have worked together for more than 20 years, and I have huge respect for her and just love that she is here with us today. So thank you, Cindy. Take it away.
Thank you, Lori. We miss you. Let me just throw that out there first. So Lori was an ombudsman for many years with me, and we do greatly miss her in the ombudsman world, but we're so excited she stayed in our organization. So that's a good thing. My name is Cindy Kincaid. I am the Ombudsman Program Coordinator, and Lori is correct. She and I both have been with this program, or at least I have, for over 20 years. And we have seen all aspects of the different things that we are talking about. But as the ombudsman, let me just kind of explain a little bit about who we are and what we do, because not everybody understands our role We are patient advocates. So we are oftentimes the voice for the residents to help them assist with complaints, concerns, making sure that their rights are being protected. Oftentimes are kind of the go-between between a resident and the facility, and trying to make sure that their concerns are addressed and resolved to the best ability we can. We have kind of a unique role when it comes to abuse, because you heard Lori mention that a lot of times staff are mandatory reporters. So if they hear something, if they see something, they have to notify somebody. About 4 years ago, the Ombudsman World put some rules that are on the federal level into place. And one of them is that ombudsmen are not mandatory reporters and cannot report without the permission of the resident themselves, which puts us in a very unique and kind of oftentimes precarious position. But the thinking behind that is we are the voice of the resident. And if the resident does not want us to be their voice, then we can't do it voluntarily. So we do spend, in abuse instances, we spend a lot of time with residents explaining what their rights are, making sure they understand what the protections are, kind of helping them understand what the process is, what's going to happen, but ultimately encouraging them to either make the report themselves because they have the firsthand knowledge, or to get their permission and we can assist them in that process. But if a resident says that they've been abused to us, but then turn around and say, don't tell anybody, we are a little bit limited in what we're able to do. So just to kind of throw that out there, and there may be lots of questions about that, and we can address those towards the end. But I just wanted to kind of let you know that, because I think a lot of people think that everybody is a mandatory reporter, and they're just to let you know, there are some of us that kind of fall outside of that purview. So one of the biggest things related to the residents' rights, and there are a number of residents' rights, and we spend a lot of time with facilities reviewing the residents' rights, what they are, how they impact the residents, the facility, the staff. And one of the big ones that we touch on is that residents have the right to not be abused. They have the right to be free from mental and physical abuse, and except in emergencies, to be free from chemical and physical restraints unless authorized for a specified period of time by a physician according to clear and indicated medical need. Now, we also include all the other forms of abuse: sexual abuse, mental abuse, physical abuse, neglect, self-neglect. All of those components fall into that right. So a resident has a right to not be abused. And when we touch on this with facilities, just like Lori said, we encourage them to make sure that not only do we touch on it in a resident's rights presentation, but that they need to have a full presentation about abuse, and that they need to go beyond that. So they need to be looking at the policies, which were stated very well by Lori or earlier. And that kind of all of those components roll up into that they have the right to be protected. And we explain that to the residents. We explain it at resident council meetings, so that not only does the resident hear it, but all of the residents hear it. We review those with families when they have questions. And so the big piece, as we're talking about rights, when we're talking about it with facilities, is it is the facility's responsibility to provide protection for their residents. And that's protection against abuse as well. And one of the big challenges that I think facilities find themselves in is that it is very hard for them to sometimes believe everything the residents say. And so that is very easy for them to discount, especially when a resident makes an allegation against a former staff or a fellow staff that's a friend of theirs. Oh, that person would never do that to them. That can't possibly be true. You don't know what you're talking about. They would never hurt you like that. I just think that you don't know what you're talking about. So they kind of put it back to the resident as, I don't believe you. And so what happens is the resident goes, well, maybe I perceived that. Maybe that's not really what happened. I must be wrong. She's right. I mean, that person would never do that to me. And so instead of encouraging the resident to talk about it and encouraging the resident to bring the allegation forward, what they've inadvertently done is encourage the resident to keep silent about it and make that resident feel like that they don't know what they're talking about. And based on everything you've heard Lori say, you've heard Wendy say, that is the complete opposite of what we want to have happen. So one of the biggest things that we try to stress to our facilities, we try to stress to the staff, is take every allegation serious. This is not a joke. This is not funny. This is not something to be made light of. Every allegation needs to be treated as if it absolutely occurred 100%. And that you start from the ground zero and you work forward with an investigation on it. And you make that resident feel comfortable. You make that resident feel like you absolutely are taking their concerns seriously, and that you are going to do anything and everything you can to try to make sure they're protected. And I mean, residents talk amongst themselves, staff talk amongst themselves. And so, if one resident had a bad experience about it, they're going to share that with the entire rest of the facility. So the next person who unfortunately may be abused or find themselves in an abusive situation is going to be afraid to say something from the get-go because they already think that nobody's going to take them seriously. Versus the resident who goes, it was really hard. And I can't believe that I had to say that, but they took me serious and they listened to me and they did something about it.
I'm not sure.
Then the next residents will certainly go, if she had a good experience under a terrible circumstance, then maybe it'd be okay if I said something. The other thing that you want to be very careful about is that your staff aren't trying to protect each other. Any kind of allegation of abuse, whether it's sexual abuse, physical abuse, mental abuse, any of those, that's potentially life-altering for the person who the allegation is made against. Okay, if it didn't happen and they go through all of this and it's determined that it didn't happen, then it didn't happen. But if it is determined that something actually happened, then they can lose their license. There's a lot. You heard the example from Lori. They can do jail time, which is what we want. If someone is guilty of abuse, we want to make sure that they are prosecuted to the fullest extent of the law. But that starts with residents feeling safe to make an allegation and staff taking the allegation seriously. So just because it's your coworker who you in your heart absolutely believe would never do something like that, we don't know that. We can't guarantee that. We don't know what happened at the house that morning. We don't know what's happening in their own personal lives. We don't know whether they may be in an abusive situation themselves. And so they inadvertently turn around and abuse a resident without even recognizing that that's what they're doing. But we want to make sure that those rights are protected. So we are oftentimes kind of the first line that a resident may reach out to. So we work very closely with that resident to say, you did an amazing job by reaching out to me. Let me help support you in being able to tell the people we need to tell. And let's make sure that this gets looked into to the fullest extent possible. So that's our role is a little bit of a unique role with the ombudsman. But the other side of our role is making sure that the staff understand the right, understand the importance of taking the any abuse allegations seriously, and to make sure that they document. You heard both Lori and Wendy talk about the importance of documentation. So at the point a resident says anything to a staff member about being abused, documentation needs to start right then and there. And it needs to be documented as clearly and as thoroughly as possible. And unfortunately, a lot of our facility staff don't know how to document. Resident was fine today. Resident said that somebody was mean to her. Okay, what does that mean? what did they really say? You know, you gotta start thinking about it from the aspect of, and you hate to say this, but if my documentation had to go to court, does it say anything helpful or useful? You know, if my documentation got called into a court case on abuse, is what I wrote clear, concise, accurate, descriptive, all of those pieces. So through our program and through folks like Lori and Wendy and, you know, we try to make sure that the staff have the tools necessary to be able to deal with these sorts of situations. As we are kind of wrapping up, the biggest piece that we really want to make sure that you understand, that you help your facilities understand, that you help the residents that you deal with, whether they're in long-term care, whether they're in a private practice, whether they're at home, you know, whether you're a home health nurse or a staff that goes out to somebody's house. If the resident can say it to you, then it is important enough for that resident for it to be addressed. Whether it's determined to be a true allegation or not. It took a lot of courage and a lot of guts for them to make that first step. Let's do our job in making sure we take it as seriously as what it is to them, and make sure that we help them get the results and get the protection that they need. Does anybody have any questions? I know there has been some questions kind of coming up. We have about 9 or 10 minutes left. I know that Lori, do folks have the opportunity to put questions in? We can read the questions out loud and have folks answer those as you know, as is appropriate. And I will be glad to read those. I know that the first couple of questions have been answered. One of the comments was when I was practicing when I was a practicing occupational therapist in another state as a state licensed and nationally certified therapist, I was court mandated to report abuse of any kind to anyone. Now that I am retired, my license and certification long since expired, I still consider that court mandate requirement to hold true. To me, that was a lifetime commitment. Now in North Carolina, as a resident advocate on a CAC, as a county CAC officially, and as Cindy said, I am not to report the abuse. However, even if it means I need to resign from the committee or forced by the county to get off the committee, so be it. I will continue to report abuse when I see it done to anyone, when there are any signs. And I understand exactly where she's coming from. One of the caveats is if I witness the abuse, I own the abuse, I can report the abuse. Where our challenge comes in is third party. So if someone was abused and then tells me about it, we do everything in our power to encourage them to then take that information forward. Absolutely. One of the other questions is, how long does it take for the LE to examine the evidence collected in the evidence kit from the physical exam? Lori, that's probably for you.
Yeah, I can answer that. So the evidence collection kit itself that we collect at the hospital, it gets sent to law enforcement, but then they send it to the state lab or Charlotte's version of the state lab for analysis. And there, right now in the state of North Carolina, there is a backlog of about 8 to 9 months for cases and their evidence to be reviewed. That means all the swabs and things that I collected and the clothing that I sent for analysis, it's going to take about 8 to 9 months before they even open my box from my particular case. And then each section within the box, there's a hair analysis, there's DNA analysis, and there's blood analysis. There's all different types of departments within that state lab or Charlotte lab that will be able to analyze different portions of that kit. So once it starts getting tested, typically, Wendy, you can correct me if I'm wrong. I think typically the turnaround once they start actually analyzing is about 3 to 4 weeks. Am I right on that?
Yeah, that's correct. And the different agencies will have, like we have a fingerprint analyst at our agency now that can do the actual crime scene fingerprints. But like Lori's saying, if they're in the box, if she's got them in the box, then that's going to be done separate. So all of that's what I was saying when I was talking about taking time. There are so many different aspects and areas of where all of this stuff goes out to that it would be hard to determine like a specific time frame, but I would say 8 to 10 months is probably a good guesstimate on the finalization of all of it.
I'm going to jump in as well. I appreciate both of your answers there, and it sounds like you both have consensus about how long it takes. One of the things that I failed to share with you guys today is that statistically, that an elder who is a victim of sexual assault, in about 50% of cases, those individuals do not live more than a year, is what the statistics tell us. So that's something to think about when we stop to think this person may not live long enough to ever see the result of an investigation that's being done on their behalf. So it's just again drives home how devastating the assault can be to an elderly person.
I'd like to add in, Lori, on that too. That is just for the actual analyzing of all of the evidence. It's not court case. Court case is upwards of 2 years. So that, like the actual court case itself is going to court and actually being heard and tried is going to be upwards of 2 years typically.
That's a great point, Wendy, but it is it's a grim thought, but you're making it. It's a great point. What other questions do we have? I haven't seen any others come through. Regina Tisdale asked if we share information with the WHO. I'm not with the World Health Organization. I'm not sure who that was. It's probably Lori speaking at that time. I don't know of any information that gets shared with the World Health Organization necessarily, like from our level, but I know that as we at the regional level or the local county levels, as things get reported up the chain to the state level, then the state reports to the federal level. The feds certainly could report things to the World Health Organization or other entities to be collected as data. I don't know if that answers your question or not.
One of the other components also, and I know Lori and the Cabarrus County Elder Abuse Task Force, is many of our local counties and communities have an elder abuse task force. And if you're not aware, if your county does, you may want to reach out to either one of us or some of the other, either probably the sheriff's office, as well as folks like Lori. Those task force are a group of a variety of professionals who do come together and talk about the abuse and ways to ensure that these protections and information is available to others. And I'd personally like to thank Lori and the Cabarrus group, because they certainly have given a strong model for other folks to try to pull together task force that are similar. And we appreciate all the work that you guys do.
Thanks, Cindy. It's a great team that we have. I know that Lori had mentioned maybe me sharing real quick one last slide. It's the one that I jumped over thinking that she would cover, and she told me after that we needed to touch base on that one maybe again. So if you close your eyes, I'll scroll down and find that one. I think it was just this one, the physical signs and symptoms. Lori, jump in if you want to. A lot of this, I think, is just a review for most of us. But the physical signs and symptoms of someone being sexually assaulted, as you might think, bruises around the breast, thighs, mouth, genital area, unexplained venereal disease or genital infections, and will also be an indicator for someone that certainly did not have those symptoms prior. Unexplained vaginal or anal bleeding, torn, stained, bloody underclothing, new difficulty sitting or walking. I have heard stories of someone who suffered a broken hip as a result of a sexual assault, simply because they were so frail and were not able to do their limit. They were limited in their ambulation to begin with, and bruises, burns, other type of physical signs of physical abuse that go along with being assaulted, any type of violent attack, and signs of restraint. So sometimes we will see those as well. But I wanted to be sure we did cover that. And Lori, did I miss anything? Is there anything that you wanted to touch base on this?
No, that's all of it. I just wanted to make sure we did cover that. And I know that you talked about the mental portion of it on the next slide, but we unfortunately have quite a few patients that come in with a mental health history, and that kind of complicates things a little bit because a lot of people around that victim doesn't believe them. And so we just need to think that even if they have a mental health history and there's difficulties there, that doesn't mean it didn't happen. And so we have to investigate regardless of their background, regardless of their history, and make a sound judgment and assessment on these patients. So just that little extra thought in there.
Absolutely, that's a great point. A resident that I worked with in a nursing home a long, long time ago, you guys know that as dementia progresses, we lose our memory sort of in a backwards way. And a resident had suffered an abuse when she was in her youth. She had been sexually assaulted, and as she and her whole family knew this, and she had great family support, thank goodness. But as her dementia got worse, that memory became more and more real to her. So she talked about being abused every single day. And we had to work with that and make sure that she knew she was safe. We felt that was one of her main concerns. And we also, of course, had to care plan that to the hilt to make sure that everyone understood. But you also don't want to make the mistake of having a resident who maybe had a past trauma and then completely ignore, and they suffer a new trauma, and we simply think, oh, that's what happened to her when she was 20. We don't need to, pay attention to that now. Yeah, it's a tough call, but that's a great point. And sadly, the majority of the folks who are sexually assaulted, as we saw earlier, either have some type of cognitive decline or some type of intellectual disability. So that's very difficult. But I'll stop talking now. I'll talk about this all day long if you let me. But I want to say a very special and sincere thank you to our speakers, Lori, Wendy, Cindy. I really appreciate you guys being here. Caitlin is our behind the scenes, making everything happen smoothly and answering everybody's questions. You will get the copies of the presentations emailed out to you, so you'll have a copy of those, and it will also be listed on our website as well, as Caitlin mentioned earlier. Caitlin, anything else before we close out and say goodbye?
No, I just wanted to mention that, like you said, there's kind of a follow-up webinar to this one next week. And so I will actually throw in the part on our website where you can register for that if you want to, and if you haven't, and that is Understanding Trauma-Informed Care. So on the 27th from 1 to 2, but that's my last little add-on. And yes, you will have the recording of this and all the presentation documents as well.
All right. Thank you, everyone. Have a great day. I appreciate you being here.